Welcome to the Ortho Case Insight Series, where trauma surgeons break down complex cases, real decisions, and the operative strategies behind them. In each episode, we hear directly from trauma surgeons as they walk through challenging cases, sharing their approach to fixation strategy, decision-making, and key lessons learned. Designed to support peer-to-peer learning, this series offers a candid look inside the operating room, straight from the surgeons who live it. Let's dive into the cases today.
Hi, everyone. My name is Sean Campbell. I'm an orthopedic trauma surgeon at the University of California, Davis. And today we're going to look at some periarticular proximal tibia fractures fixed with the EVOS SMALL Plating System. So the first case, this is a case I did recently. This was a 40-year-old gentleman. He fell from an e-scooter about 7 days prior to presenting to us. So he had this proximal tibia fracture dislocation for about 7 days. He had a history of housing instability and substance abuse, and he had pretty severe fracture blistering medially, but normal neurovascular status, pulses, and no compartment syndrome. Here are some additional images. You can see after a closed reduction was attempted and a splint was applied, you can see the knee is still dislocated. You get the sense that there's this large medial articular fragment and some lateral central articular comminution. And so the first step here was a closed reduction and knee spanning external fixation. And you can see we're using sort of a multiplanar frame. In this situation, we have an anteriorly based frame, which is my usual frame. But I find for these medial fracture dislocations, that alone is sometimes not enough to restore the coronal translation and the knee dislocation. So one thing you can do is put a medially based frame on as well and use that to help reduce the dislocation. And essentially in the central image there, we can see we've got it pretty well aligned now. And again, we get the sense that there's one large medial articular block and some fragmentation of the lateral joint, particularly centrally. And we're getting the sense that this is really a OTA-AO-B type fracture. The whole lateral column of this is intact. And on the far right, we can see there's some shaft extension to deal with as well. Here's a look at the CT scan, kind of confirming those articular fragments push deep down into the lateral metaphysis and shows us the extent of that shaft extension. And then some select cuts from the other reformats. We see, again, one large medial articular block on the coronal and on the sagittal. We're starting to get a better sense of the orientation and details of these lateral articular fragments that are deep down in this metaphysis. And this confirms also that the far lateral joint and metaphysis is actually intact. So planning considerations for this case, we're going to want a very strong, stout, medial buttressing implant to hold this knee reduced. We're going to want some way to access those lateral joint fragments, so we'll have to think about that. And we're going to need to neutralize the long shaft extension. So here's what we did. I like to start with contralateral images. They help me understand what this knee is supposed to look like. And one thing that's particularly helpful, I think, on these is we get a sense that this person has a little bit of a varus medial proximal tibial angle, where the medial joint is a little bit lower than the lateral joint on the AP, but not a lot, maybe a few degrees. And I find that useful information when I know the medial column is probably going to be short. And so here's, as we proceed through surgery, the first thing I did on the far left, you can see I put a lag screw by technique across the shaft extension. And then that let me restore the medial column length without that displacing. So we put a medial distractor back on. And you can see on the far left, the medial plateau is well short of the intact part of the lateral plateau. So that column is short still. So we're going to use our distractor to restore that length. And then on the far right, you can see we're trying to restore the slope by preferentially tipping the anterior part of that medial condyle up to get the slope back. And once we have it where we want it, we are using a stiff, stout posteromedial plate to buttress this. And think this is one of the nice things about the EVOS proximal tibia plates is we have a lot of options. So in this case, we need this really stiff, strong cortex replacement plate, basically, to prevent this redislocation. And we're posteromedial, so we're using the posteromedial version. But there's also a direct medial plate that like this if you need that. And then I really like the partial articular plating options as well, which are thinner and more flexible. So if you really want a plate that's going to auto contour nicely and generate a lot of articular compression, that can be a good option. So we got the medial column fixed. We've kept implants out of our anticipated lateral reduction area and lateral implant area for now. And now we're going to the lateral side. We're using a lateral distractor to look inside the joint. And we can correlate the radiographic shadows we see with the CT imaging that we know about, and we know where those fragments are. So how are we going to access them? One option that I find useful is we can do a lateral wall osteotomy. And so this is sort of a multiplanar osteotomy. And we're really just going to create a little trapdoor into the metaphysis. And so we can hinge that back on the posterior periosteum that we keep intact. And now we can access those fragments and kind of dig them out and put them back where they go. And we get them realigned. We can see them through the joint. And once we've kind of driven them back up through the hole they came down through, and we're holding them with a bunch of wires, you can see our little trap door right here. And once we get that reduction done, we're going to backfill that metaphyseal void with some allograft, put the trapdoor back down. And then the middle panel, we're applying a stiff, stout buttressing implant to create some compression. And then on the far right side, I like to put multiple cortex screws, 3 or 4, all in, and then tighten them all down together sequentially, kind of like tightening lug nuts on a car tire. And we're going to drive that articular compression while these wires we've placed in the subarticular zone prevent cranial shearing of those fragments. And then finally, you see we selected a very long plate to neutralize that shaft extension. And this is going sliding down under the anterior compartment distally. And we're applying these screws percutaneously. And I like this feature. There's these percutaneous insertion sleeves that we can use. You see them on the far right. They screw into the plate holes. And I can drill and measure and even put the screws in through those sleeves. And it just saves time. I used to, tie suture onto the screw heads to prevent them getting lost in the anterior compartment. And this, I find, saves time and energy doing this more easily. And so here's our final construct. I have seen this patient back once. He's still early, but anticipate he's probably going to do pretty well. Moving on to case number 2. This is going toward the reconstruction side. So this is a failed bicondylar fracture. And so this is a bicondylar non-union of the metaphysis with a malunion of the lateral plateau. And we'll get into that a little more. This is a 30-year-old female. She sustained an injury and was treated at another hospital about a year before coming to see us. And she can't really ambulate due to pain on this side. She notes the limb is deformed. And unfortunately, she's got a bone defect on the other tibia. So she's really just wheelchair bound for the last year or so at this point. Here's a clinical image showing the limb, and you can see this fracture initially was all fixed through a single anterior exposure, and she's got an obvious varus deformity, and a rotational flap was used to cover this, and some full-length tibia films showing the varus alignment. And you start to get a sense of the slope differential on the lateral plateau and also the non-union of the metaphysis. Here's a CT scan. It shows that the medial side of the joint, the medial articular block, is all one fragment you see there at the top. But then as we go over to the lateral side, we see this divot down into the lateral joint where the front of the joint is rotated clockwise and the back of the joint is depressed and rotated anti-clockwise. And so it's a lateral articular malunion. Here's the coronal. This kind of highlights the metaphyseal non-union we see, metadiaphyseal non-union. But you can also see when we look at the front of the joint at the top, the anterior lateral joint is high. And when we scroll to the back, it's too low. So what can we do for this patient? I like to separate these failed periarticular fractures into their extraarticular and intraarticular components. I find that helps me come up with a plan. And so on the extraarticular side, we need to decide if this is a mechanical issue primarily or a biological issue. And to me, this is mostly mechanical. I think it's invarus. Maybe it was fixed that way. I don't really know. But I think if I can get that out of varus and compress it well, I can get that to heal. And then on the intraarticular side, the main question to ask, is this joint salvageable or not? And I thought this probably was. And my approach to this is that this may be amenable to an intraarticular osteotomy to repair the intraarticular malunion. And even if it's not, if I can get the overall limb alignment back to normal, the patient might do pretty well with this malunion. So I was going to look inside at this and decide at the time if this was something we could proceed with an intraarticular osteotomy or not. And then obviously we have some flap management issues to deal with here, some soft tissue management. So I enlisted the help of one of our excellent plastic surgeons to help me expose and deal with this flap and then get it closed down and healed again. So here's what we did. You see, we took out most of the implants. And we should mention at this point, this patient had normal inflammatory markers. There was no sign of infection on this side, et cetera. So we feel comfortable treating this all in one stage. So take out most everything. We're going to restore the alignment now using a medially based distractor and a fibula osteotomy. And we dial in that medial proximal tibial angle to be right where we want it to be. And then here we're using, again, a very stiff stout plate, but now a direct medial plate since we're more on the direct medial surface. And we're going to apply that to hold that alignment for us. And one other thing to note, unique to the system, we're using a high torque or osteopenia style screw. You can see it as the third screw from the bottom there. And they just have these very large threads. And I find that very helpful for this kind of situation where the bone quality is abnormal. Here it's abnormal because of the disuse osteopenia. So once we have it aligned, we went over to the lateral side and I did an arthrotomy and looked inside the joint. And it turned out those cartilage pieces looked quite good. There was just a divot there. And I thought it was something we could repair. So we did a multiplanar intraarticular osteotomy, basically recreating the old fracture. So on the far left and central as well, you can see we have the osteotome turned so that we're making an axial plane osteotomy. And then once we have that freed up, we're going to go recreate the old fracture line, and we're doing an osteotomy in the coronal plane, all the way up through the subchondral bone, but not violating the cartilage. And that allows us to sort of pop that divot out, almost like taking a dent out of a car door. We can prop it back up, and then we're going to hold it there with wires. And now it's just like fixing a tibial plateau fracture. We're going to backfill the void, and we have lots of anti-shear wires. We're going to buttress this to create some articular compression, and we're going to put non-locking screws across to create additional articular compression. And here we're going to now compress our metaphyseal non-union. So we have this compression-based clamp in. It's available in the advanced reduction set. I like this thing a lot. It's kind of just like an ATD device, but I find it more convenient and easier to get onto the side of the tibia. So it's a screw-based clamp, and I'm pulling on the plate against that post screw, and I'm generating compression across the metaphyseal non-union. And the other thing that's subtle but I think effective is in this situation we have bent this plate. I've over contoured it, and that is going to facilitate some additional compression, axial offset compression. As I pull the shaft over to this plate, I'm going to create compression against this subtle obliquity, and I've achieved that by over contouring the plate, which is really only something you can do with a stainless steel implant, which is another reason that I like these implants, because I think they allow us to apply them in the working modes that we want our plates to work in. And then finally, the last bit of compression we can generate across this non-union is a lag screw by technique on the right side, you see there. And some people call that an anti-shear screw, but it is also an effective way to create some additional compression at the end of the case. So here are the final images from the operating room. Alignment looks pretty good. Lateral joint looks pretty good. And here's our alignment series. Looks pretty reasonable. You can see we still have some work to do on the right side, which has a bone defect, which we're actually working on right now. And here she is 6 months later, now able to put weight on this side. So making some progress on these bilateral tibia problems. The third case we'll talk about is periarticular fracture with the segmental shaft fracture. And so this patient was a 50-year-old man. He was a pedestrian struck by a vehicle, and he sustained bilateral type 3B open segmental tibia fractures. Here's a clinical photo from the emergency department on the night of arrival. And you can see the soft tissues on the right side are certainly worse than the left, but the left is still a large wound that looks like it's going to need some type of plastic surgery to help get covered up. The right side, unfortunately, this was the evolution of the soft tissues, just progressive necrosis. And so we ultimately did an amputation on that side. But I think the left side has some interesting learning points we can talk about. So this was our temporization on the night of presentation. And you can see we've used a combination of damage control plating for the more proximal of the diaphyseal fracture lines. And we've used a knee spanning external fixator to realign the bicondylar fracture. And then we're using our external fixator to temporarily hold the alignment of the more distal of the segmental fracture lines. This is what the wound looked like. And that actually did not evolve much from there. So it stayed that size, and the rest of the tissue was healthy, and the patient was deemed to be a good candidate for a free flap to cover this up. So now we're talking about how to stabilize this skeleton. And so for me, I like to take a joint first approach to these. I feel if I can get the bicondylar alignment and the knee stability correct, the shaft I can do plating for. And if that goes on to non-union, I can deal with that later. So I personally don't try to stretch my extreme nailing to these periarticular fractures usually, but some do, and it can be a good option. But here we're going to use all plating to fix all this stuff, including the shaft. So this is sort of a joint first, diaphysis second strategy. So here's what we did. Articular fracture first. So we've got traditional posterior medial and lateral fixation. We've got our reduction complete, and you can see here we're generating compression, and there's our sort of final construct. We use some independent screws to capture the free tibial tubercle fragment. Here's what we did for the shaft. So we're using this long anterolateral plate in compression mode. And we apply this percutaneously just through a small incision down at the ankle, slide it up under the anterior compartment, and we've anchored the plate to the distal segment, and we create this axilla between the plate and the bone. And now we can do a compression plating. And so here we're using that same clamp, that compression clamp I showed you, but this time we're using it between two plates, and we're going to generate compression across that fracture. And once we have it compressed, we're putting screws in the plate and holding that. And so here's our final alignment at the knee and final alignment of the bone. And you can see we also stabilized the fibula, and there was a proximal tib-fib joint dislocation that we stabilized as well. And one thing to point out here is that the more proximal diaphyseal fracture line is right through here. So we did leave our damage control plate on, and we have a few screws past that, but you'll see why that becomes of interest in a minute. Patient gets a free flap, and at 6 months, he's looking quite good. His soft tissues have fully healed. His knee has healed, and is functional, but you can see that proximal fracture line has gone on to a bit of a non-union. He's got some heterotopic bones forming, but he's got varus alignment, and he hurts now. He can't walk on it anymore. So another periarticular failure. We're going to ask that same question. Is this extraarticular or intraarticular problem? And this one is just a pure extraarticular problem. It's really just a hypertrophic non-union. And the next step is, do we need to correct the mechanics or the biology? And to me, this is really a mechanical issue. This was just me not providing sufficient stability during the index treatment for that fracture line. And now he's in varus alignment. Okay, so I thought nailing would be a good way to correct the biomechanics. And so here we're establishing our starting portal, and we're taking out implants as needed to get our guide wire down across the non-union. And we're using a medial frame to restore the coronal alignment, get it out of varus. And then we can ream across and put in our nail. And we're just going to generate some compression through our nail. Here's what that looks like. And here he is at a year, all healed, back to ambulation. See a bit of residual varus alignment there, but clinically he's doing quite well. So to conclude, I think we should probably talk about why EVOS SMALL is a good system for fixing proximal tibia fractures. And I think there are a few reasons that stand out to me. One is the number of options available. I really like the ability to have a posterior medial plate, an anterior medial plate, a direct lateral plate, a partial articular thin version of those plates, or a stiff stout version of those plates. And I find that very useful for different situations. The other thing I like is the fact that these are all stainless steel implants. We talked about this a little bit earlier, but if I can bend and contour the implant, I can over contour it, under contour it. I can make a wave plate out of it. I can bend it such that I'm going to create additional compression in one plane or the other. And so to me, that material is really the fracture surgeon's material, and I appreciate that. And then I think there are some really interesting, innovative features of the system that make applying the implants easier, that were clearly designed with a lot of thought. And so some of those we've seen in these cases, but examples to me are the high torque screws that come in various sizes, both for small and mini fragment. I find those very useful. The percutaneous insertion sleeves to put screws in through the anterior compartment while protecting the anterior compartment and preventing loss of the screw is super useful. And then things like the new compression clamp, which allows a screw-based compression that's easier to get in than some of the traditional devices, I think are just signs that the team was thinking about how are these implants going to be used and how can we make it easier for the surgeon. Thanks for watching. Hopefully you learned some good tips and tricks you can use when fixing these periarticular fractures. Thank you.